Welcome to the Hormone Optimizing Warrior MD, the How MD podcast, your reliable and trusted source for information on hormone therapy for menopause and beyond, and on how to advance into the second half of your life with confidence and optimism, knowing your hormones are optimized in alignment and balance with everything else in your body. Whether it is hormone therapy, peptide therapy, laser therapy, or some other new technology applicable to maintaining our vitality, mental and physical strength, you will hear all about it in this podcast. And you will also hear how to implement the facts and information presented so that you can take action and optimize your hormones and optimize your body. Hello and welcome. For the past few weeks before my rebranding episode, I discussed the value of breast cancer surveillance in general, and especially when it pertains to using hormone replacement therapy for menopause, as the estrogen or testosterone or progesterone can cause breast cancer scare is still fresh and raw in women's minds from all kinds of twisted facts and information that is 20 years old and not at all applicable to the majority of available transdermal therapy options we now have available. Now, the heart scare was the second most important reason that doctors worldwide and their patients were given to stay away from hormone therapy, because in 2002, all women and all doctors were told that hormone therapy after menopause will increase the risk of a cardiovascular event. And by that, I mean a heart attack or a stroke. What's interesting is that the study was completely correct and accurate on this fact. The hormone therapy used in the World Health Initiative study, which was called PrimPro, and contained a combination of horse estrogens, about 17 of them, derived from the pregnant horse's urine and synthesized into the form of a pill, combined with a synthetic progestin derivative called medroxyprogesterone acetate, was not good for the heart. This specific combination created a significant increased risk, even though the risk was much smaller than what was presented in mass media and made headline news. It was important. This type of therapy was bad. That's what we should have learned from the World Health Initiative study. Instead, the entire world was told that estrogen is bad. Again, that specific hormone combination in that specific form was bad. And that's where the truth stopped. And this is another truth for you. You were told that hormone therapy for menopause increases risk of clotting and heart attack and stroke. But here's another truth that no one is really shouting from the rooftops. Any oral estrogen will increase risk of thromboembolic complications, including the widely prescribed birth control pills, which are given to tens of millions of women in the US, probably hundreds of millions of women worldwide, without telling them point blank that they are at risk. The risk is minimal, is small, but it's not zero. And here comes another truth, and one that matters greatly. Transdermal estrogen in the form of a cream, a patch, a vaginal product, or a pellet inserted under the skin do not cause an increased risk of cardiovascular events because they are bypassing the liver, which is the key reason why oral estrogen increases the risk of clotting, because it is subject to what we call first pass liver effect. It goes to the liver, it activates an overproduction of clotting factors when it's being metabolized by the liver. We humans are very resourceful. We quickly found out that giving estrogen in the form that bypasses the first pass liver will be safe for the heart. So here comes the patch, here comes the cream, here comes the pellet. This message and this truth about transdermal estrogen has been widely known by many physicians, but it has not spread like wildfire as it should have been, because the truth is estrogen can save lives and can protect women from heart disease, which is exactly what, unfortunately, estrogen after menopause is wrongfully being accused of. And I'm happy that the FDA removed the black box warning on all the transdermal and topical vaginal estrogen products, as it should have. because that black box warning should have only applied to that specific medication used in the WHI initiative study, which was Primpro. And think about this. It took 20 years or more for the FDA to remove the black box warning, even though we had 20 years of study and science and research to back up the need to remove the black box warning. So I'm not a conspiracy theorist person, even though I enjoy a good one here and there. But why this bad juju and this bamboozling around estrogen? Why? Well, in today's episode, I want to start the discussion around cardiovascular health maintenance while a woman is using hormone therapy for and after menopause. And this could apply just as well to aging women. And I want to discuss the influence hormones have on some biological markers, indicating possibly increased risk of heart disease or cardiovascular risk in general. Now, I don't want to bore you right at the beginning with statistics, but the real truth that is not evident to all women, and it's not really the top of their mind, is the fact that the number one killer of women after menopause is heart disease, not the greatly feared breast cancer, and not any other form of cancer. As a matter of fact, in recent data from the CDC, about 300,000 women die every year from heart disease, and about 250,000 women are dying annually from all cancers combined. Yes, the numbers are comparable, but the lethal damage caused by heart disease is beating by far all types of cancer in women, and this is hugely ignored. Cardiovascular health and heart disease in particular are highly complicated. There's not one single specific biological marker like, hey, you got a tumor marker for cancer. You don't really have a biological marker that would indicate your level of risk. That is why understanding your heart health risk factors while you age and spend the second half of your life either without estrogen or with estrogen therapy is so important. Well, I would lose myself in the risk factors if I start talking about them. I did that in previous episodes last year, maybe at the end of 2024. When I talked about wellness exams and what a doctor should look for, I had this topic covered. I'm not going to do it here. But what I want you to take away from today's podcast episode is that for a woman entering menopause and spending the rest of her life in the postmenopause years, her biggest risk factor will be losing her estrogen. Estrogen deficiency. That is your biggest risk factor for heart disease. We all know that. You, the listener, know that. The patients know that. Your doctor knows that your biggest risk factor for cardiovascular disease and heart disease after menopause is the fact that you lost your estrogen, right? So how many cardiologists have you seen that are talking to you about how important estrogen is for a woman? How many cardiologists are asking you, hello, have you had your estrogen levels checked? The answer is probably 0 or 0.0001. When we talk about important biological markers for cardiovascular health as a woman ages, consider the level of estrogen and the level of your FSH. Many women do not know what FSH is, but FSH stands for follicular stimulant hormone. It is a pituitary hormone made by a very specific part of your brain in response to low estrogen. The lower your estrogen will be, the higher your FSH will go. Your body will make more and more FSH, trying to get your ovaries to produce more estrogen hormones. After menopause, your ovaries are done because they have run out of eggs. There will be no more estrogen output. Therefore, your follicular stimulant hormone, your FSH, will significantly increase. When a woman is replacing her estrogen deficiency with estrogen therapy, please ask about your FSH. FSH is an overall indicator of a woman's general status of estrogen deficiency. Many women who use estrogen creams or patches still have elevated FSH because they're treated to reduce or control symptoms, not to optimize their health, and definitely not to optimize their cardiovascular risk. It is true that treating your symptoms only, specifically your vasomotor symptoms, also known as hot flashes, you will greatly decrease your risk for cardiovascular disease. Why? because we know now very clearly that hot flashes are bad for your heart. They create anxiety, they disturb your sleep, they increase your blood pressure and your heart rate. And in the long run, they can be very damaging to your heart and your blood vessels if left untreated. We know this, and I pity the women who are told by their physicians that they need to power through the hot flashes, that the hot flashes are natural and eventually they will go away. Hot flashes are not something that women have to power through. Hot flashes are a significant symptom of estrogen deficiency, and they can have serious consequences for a woman's overall cardiovascular health. Hot flashes need to be treated. And we, the medical providers who know and understand hormone therapy and what kind of magic it can yield and the devastating consequences of the loss of this major hormone in a woman's body, we need to be clear with our messaging. Hot flashes are bad and they need treatment. The treatment for hot flashes is needed to prevent damage done by these vasomotor symptoms of menopause. The rapid heart rate will put a strain on your heart as it will be repetitive. And with each hot flash, the more severe and frequent they are, the more strain on your heart. During a hot flash, there's a rapid and significant expansion and constriction of your blood vessels. And these ongoing persistent fluctuations will, in time, damage your blood vessels. Hot flashes cause major sleep disruption, which will negatively impact your health and specifically your heart health, because it will contribute to inflammation and risk for high blood pressure. Hot flashes will be accompanied by significant anxiety, which triggers a fight or flight response. Your body does not feel good. You feel like you're on fire. You feel like you're about to die. Your heart beats out of your chest. This is not good. It will be accompanied by an elevation in the blood pressure, will trigger inflammation in the body, and unfortunately, all of these things that I just mentioned will influence lifestyle choices, which contribute to a further decline in your physical activity. You're going to eat poorly. You have an increased risk of substance use like alcohol, tobacco, marijuana, and everyone knows how important lifestyle choices are for the risk of heart disease. So in conclusion, a smart cardiologist, a smart primary care or internist who is addressing your heart health after menopause should always ask you about hot flashes and should know that they need to be treated, because untreated hot flashes are really, really bad for your heart. If you have a cardiologist that tells you estrogen is bad for you and you should power through your hot flashes, or doesn't even ask you about hot flashes and just writes you a prescription for high blood pressure medication, anxiety medication, or sends you to a psychiatrist, please give them this podcast episode to listen to. They might learn a thing or two. In conclusion, for the sake of moving forward to the other biological markers I want to talk about that reflect cardiovascular health for postmenopausal women who are using hormone therapy and which we need to monitor when they are under hormone therapy, please ask whatever physician is treating you for your cardiovascular health or recommending medications if estrogen matters when it comes to your heart. If they say, yes, estrogen matters, they are a keeper. If they say, no, estrogen does not matter, you're just in menopause, your estrogen is gone, what's estrogen got to do with it? I strongly advise you to reconsider and seek a second opinion from someone who is well-versed or better versed or educated in women wellness and menopause care. I've said this before and will say it again. I do believe that the governing bodies of physician certification and accreditation should make menopause therapy training mandatory for all physicians involved in treating women for general health conditions during and after menopause. Why? Because your cardiologist, your primary care doctor, your internist, or your OBGYN might be someone you see on a regular basis. And once a woman walks into a primary care doctor, an internist, an OBGYN, a cardiologist office complaining of hot flashes, she should be treated as seriously as someone with diabetes or someone with depression or uncontrolled hypertension. Because early treatment could mean a lifetime of protection and significantly decreased risk for heart and blood vessel wall damage. So talking about hot flashes and how impactful they might be should be more important than doing a pap smear. Talking about hot flashes and how much they disturb a woman's life and well-being could be more important than simply looking at cholesterol and prescribing a statin. Again, ask your cardiologist to listen to my podcast. Now, of course, your cholesterol will change with menopause. Of course, the loss of estrogen and the severe estrogen deficiency will snowball into a series of unfavorable changes of your lipid profile, inflammation, and other hormonal disturbances, which could easily be avoided or delayed. Eventually, we all get older and die, but if the severe estrogen deficiency at menopause will simply be treated as a real medical condition, it will all be avoided. Again, menopause is no different than any other medical condition, especially chronic medical conditions. Unfortunately, it's not considered a chronic medical condition, but it's a natural biological transition marking the end of a woman's reproductive life. And this is how most doctors are viewing it. That's an opinion we need to change. We need to stop considering menopause something natural that all women just have to go through. Again, we understand menopause is inevitable. You understand that. I understand that. All your doctors understand it. But so is death. We all die. We do not tell someone with cancer, just wait for death. There's nothing we can do. We treat cancer patients with respect and consideration. We give them the best care we can according to the most up-to-date knowledge as how to fight that specific cancer and prolong life. We fight alongside the patient because their life matters to them and to us. It is true that menopause, just like endometriosis, PCOS, osteoarthritis, or osteoporosis, is not a lethal condition per se. However, all women should have the basic human right to understand menopause as being the beginning of how they will live their life without estrogen, without progesterone, and without testosterone, and how this massively important and severe hormone deficiency will not only impact the rest of their hormones, how it will impact their heart and their cardiovascular health and their quality of life from the age of 50 until their death. All women have the basic human right to know the truth about menopause and to understand they have options. That there are physicians who consider menopause a medical condition, or at least consider menopause a natural biological transition complicated by chronic medical conditions intimately connected and interrelated with the loss of the most important nourishing hormone for a female human body, their estrogen. Now, I will end here and I will have more to come on this topic of menopause because the next episode is going to be about cholesterol. I will talk more about the truth about menopause, how it is a basic human right for all women on this planet to know the truth about menopause, to know the truth about hormone therapy, instead of being bamboozled with facts and information which hides the truth from them. So all of this and more will be available on my Substack platform being launched on May 1st. I will end this episode here and I will continue in next week with a discussion about monitoring lipid profile and cholesterol during menopause, and especially the consequences of using hormone therapy for menopause on cardiovascular health and specifically your cholesterol numbers. So stay tuned for that. And I guess this episode was a little introductory to the heart health, and I hope you got the message that all your doctors have to be trained in how valuable estrogen is for a woman and how when they lose it, things change. And just like psychiatrists have gotten very smart and are sending women to a hormone specialist to get their hormones balanced when women come to them in their late 40s, mid 50s, even in their 60s with what's clear, a mood change or a chronic mood condition caused by a hormone deficiency, and tell them, hey, you got to get your hormones fixed. So should the cardiologist come to the table and say, hey, listen, your cholesterol is now 240. And 5 years ago, it used to be under 200. Maybe you should go see a hormone specialist and consider estrogen replacement because it will be good for your cholesterol. Or your cardiologist or internist or primary care doctor should be like, okay, you haven't had a period in 3 to 4 months and you have hot flashes. Let's test your hormones. Let's address that. And if they don't know how to do it, they should simply send you to someone who knows how to do it. I appreciate your time and patience and your dedication to listen to this podcast, and I will see you again next week. Thank you for the time and energy you spent listening to my podcast. If this episode or another have caught your attention and delivered valuable information you have not heard anywhere else, and if you feel I have succeeded in my mission to provide the how to stay healthy and age beautifully, please leave me a review. Your opinion matters to me, and any suggestion to improve the podcast will help make it better for you and for others. You can send my staff a message directly by sending an email to receptionist@herahealthcare.info. I look forward to recording my next episode and being in your ear again.